show if anyone Alahif. Hi. Hello Dina. Hello Moza. Okay, so we'll wait for a few minutes or seconds so will people join, and then inshallah we'll start. Hi Hiba, Sarah. Okay. Hello everyone. Okay, so yalla, bismillah ar-Rahman ar-Rahim. We'll start now because sorry for the bit, we are 5 minutes late, we are running out of time because due to some technical issue, okay? So, I don't know if everyone knows me well or not. My name is Dr.Anas Alsalami. I'm pediatric dentist and pediatric and special needs dentist, both usually because it's almost very common to have both together. I graduated from the MBRU, Mohammed bin Rashid University, and I got my membership in pediatric dentistry from the Royal College of Surgeons from Edinburgh, UK. And I'm glad to meet everyone here, and hello everyone. Okay, so I'm going to talk first because one of you have asked me about the pediatric dentistry, the specialty of the pediatric dentistry. I can tell you that pediatric dentistry, it's not as like many of the people in the undergrad or even in the general dental practitioners, they do believe. When I was in the undergrad, I used to hate pediatric dentistry, I can tell you. But now I can tell you I'm 100% shifted now from hating pediatric dentistry to loving the pediatric dentistry. And that's because of they taught us exactly how pediatric dentistry, the real pediatric dentistry, how it works. Because in pediatric dentistry, the good thing about it is that we are not looking at the patient's teeth or the child teeth only. We look at the patient as a whole child. So that's very nice about it. And when you think of like having a child with you in the clinic, and you need to consider many things with the child, his behavior and his attitude. So and it gets more attractive and interesting when you have this kind of stuff with you in the clinic, other than looking at searching for the cavities in the mouth and treating the cavities, restoring the cavities in the mouth. It gets a bit more frustrated by a few years. So that's why I can tell you that that's the difference between the pediatric dentistry and real dentistry. So basically, pediatric dentistry, why I used to hate it when I was in the undergrad? Because I had only my local anesthesia to numb the tooth and treat the accused tooth with whatever the causes and whatever the situation or the behavior it is. So now, as a pediatric dentist, I can tell you the situation is completely different. I'm not having my local anesthesia all the time beside me because I have other stuff to treat the child, other techniques to treat the accused tooth other than having the local anesthesia all the time beside me. So when you have a child, usually because the age range of treating the pediatric or the pediatric dentist, we deal with the children in the pediatric dentistry. The age range is from the child from the birth or from the first tooth that it drops, or we can say from the first birthday until the age of 16, which the children or the adolescents have all the permanent teeth in the dentition. So we make sure it's like a transition from the primary dentition, mixed dentition, and the permanent dentition. We will follow on this transition from the primary to the permanent dentition. And once we make sure that the child has good permanent dentition and he knows of how to take care of his permanent dentition, and then they leave us. Unfortunately, sometimes they look taller than us. We used to see them, they are too small, and by the time they reach 16, they are much taller than us, and we need to refer them to the general dental practitioners. So in pediatric dentistry, Why I love the pediatric dentistry now, which I used to, not to hate, but I used to avoid treating children when I was in the undergrad. For your information, during my undergraduate studies, I used to love, my passion was more in the oral endodontic treatments, root canal treatments, and oral surgery. And my third option in the undergrad was to go for pediatric dentistry. And what had pushed me to go for the pediatric dentistry is like I had to choose from all these aspects of my interest, my passion, and my skills. First, I thought of going for oral surgery, and many of you might love to continue your career as an oral surgeon, which is a very good subject, and if you love it, you have to go for it. It's a very nice specialty. But the options that I had in the Middle East, most of these specialties were oral surgery, and they were not oromaxillofacial surgery. And I don't encourage you to go for the oral surgeries alone. And the best specialty if you want to go for future is to go for oral and maxillofacial surgery. And look for the universities or postgraduate studies that they do offer oral and maxillofacial surgeries. And my other option was to go for root canal treatment. And once I thought that, oh, Anas, are you going to do everyday root canal treatments? I said, no, I'm not going to do every day to open the access and do the root canal treatment and see the patients with irreversible pulpitis. I love that, but I say that I'm not going to do that for my whole life, to look at the very tiny canals and do the root canal treatment. And then I thought of, okay, so my third option would be the pediatric dentistry. So why I choose to go for pediatric dentistry? Pediatric dentistry, actually you have its combination of all the specialties of the dentistry in a child. So basically, we do root canal treatments for a child for 6s or 7s or premolars. And we do surgeries, which I'm saying that I love endo and I love surgery, but now I'm a pedodontist. So we do root canal treatments for children. We do surgeries, oral surgeries. What kind of surgeries we might do for children? Many children, they might come with the supernumerary impacted teeth, or with like cyst, or with mucocele, or whatever the reason is. So these kind of pediatric patients, they might not go directly to the GPs or to the specialists in oral maxillofacial surgery, because many of them, they are anxious and they are scared of going to the scared of going to the general dental practitioner or oral maxillofacial, because they are not really specialized in dealing with the children. So basically, it's a cocktail of all these specialties, with dealing with cute patients, small patients, very adorable patients, young patients, which you really love. I can tell you, even if you come to the clinic, you're in a very not good mood, whatever the reason, you come to the clinic, you don't have a good mood. But when you see children and you see they are playing, they make fun, and you sing together, play together, it's automatically it will change your mood. So from being sad, for example, in the clinic, you start your clinic, by the end, the time that you left the clinic and you leave the clinic and you are so happy and your mood is just, it goes high. So that's a good thing about pediatric dentistry. I know many of you who are intern or doing your undergraduate studies, you're not really keen to go for pediatric dentistry because you have difficulties, and I agree with you. Because in the undergrad or even with the GP, having a pediatric patient is not always feasible, or it's not always achievable to do the treatments. And that's not because of you don't have the skills, because you have other alternative techniques which are only available with the pediatric dentist. So let's go to the treatment planning and the skills of the that you have in case that you are in the pediatric dentistry and don't have with general dental practitioners. In the pediatric dentistry, usually the treatments is divided into 3 categories. Either you do the treatment under local anesthesia, which is in the dental chair, or you do the treatment under the inhalation sedation, nitrous oxide, or in some cases you might do IV sedation or intramuscular sedation or oral sedation in some cases. And in severe cases, like very extreme, our last option is always to go for the general anesthesia, where the patients go completely unconscious, the patient will be sleeping, and we do the full mouth rehabilitation treatment of all the teeth under general anesthesia while the patient is asleep. So we are not. So being an undergrad or being a GP, you have only the first option, which is treating the child under local anesthesia in the dental chair. So when do we decide to which treatment we'll go? A patient comes happy, smiling, with a good previous dental history. He's not anxious. He doesn't have any anxiety. He's come to your clinic, and patient is happy to receive the treatment under local anesthesia. Then a GP can do that. A pediatric dentist can do that. And in the other hand, if patients come a bit anxious, patient is 6 and 7, he understands, he had a bad history, dental history from the previous extraction, for example, and you don't know if patient is anxious and you need to do the treatment because of the patient is in pain. So in this case, the nitrous oxide sedation most of the times will work, because the nitrous oxide sedation, which is part of our topic to discuss today, is quite safe and it's very effective in most of the cases if the patient is understand the technique and less anxious of what's doing. So we can go for the nitrous oxide sedation. And in very severe cases, in very young patients, like 1 year or 2 years old patients, when the patients come to you and the patient is in pain or patient comes with a trauma, there is no any other option than treating the child under the general anesthesia. General anesthesia, it is said to be safe with some risk to the central nervous system if the patient is very young, and that's why we always try to avoid that. And you definitely will face the difficulty with the parents. With many parents, they don't want to expose their children to the general anesthesia. So in that cases, then you need to work with the other alternatives. And to be honest, the way of practicing pediatric dentistry and undergrad is completely different. Many of you might restrain the child. By restrain, I mean holding the 2-3 people, they come and hold the child and hold his hand, hold the father come and hold the legs, and someone holding the head of the child, give local anesthesia, patient is crying, you don't know if the anesthesia is working or no, you pull the tooth out, bleeding, patient go out, and patient will never come back to you. And will never come back to you even if he gets older. So that's the practice. We'll never do that. So I don't suggest you, I don't encourage you to do this kind of restraints to any child, because that will affect future, the history of the dental history to the child and dental experience to the child, and that will affect the children when they go to the adulthood. So as we say that the treatments is divided now to local anesthesia, and divided into having the sedation and general anesthesia. So today we'll talk about the nitrous oxide sedation, and at the end of this discussion we'll have a demonstration on the technique and how it works. And I'm going to try to one of our residents here, first year resident, Dr. Mustafa. It's his first time to try the nitrous oxide sedation, and he's very enthusiastic and keen to try it on the. For him, it's his first time. Although he got used to use it for his patients, but he has never tried. And I always suggest all the postgraduate students or residents to try the nitrous oxide sedation on themselves, to have the feeling, and then they can use it for their patients, so they can explain, they can express the feelings that they feel. So today, now I will go and have a quick theory revision of the nitrous oxide sedation, and then we are going to try it as a demonstration on one of our residents here. So let's talk about the inhalation sedation. It's a very nice article. It's from the Pediatric Dentistry in the Dental Update. It is by Dr. Ginos Tahmasbi from the Leeds Dental Institute from UK, and it's called Pediatric Dentistry in the New Millennium, Use of Inhalation Sedation in Pediatric Dentistry. So I'm going quickly just to review. I have highlighted some of points here for you regarding the inhalation sedation. So we review it together and theoretically, and then we'll go to have the demonstration on the real life. So anyway, if you want this article, I can email it to you, or I think the team they will post it in the website. So check it out in the website. If you couldn't find it, please email me. I can send you the article. I do recommend it to you. It's very easy written in the language. Is so easy for you if you want to read it. So inhalation sedation. The technique of inhalation sedation with nitrous oxide and oxygen is an effective method of reducing the fear and anxiety and pain and improving the patient cooperation in both children and adults. It is an easily, yes, thank you, Dr. Have. If you can see here down, this is a website, and most probably, he will put it uploaded for you. Thank you, Have. Yeah. So sorry for that. So it is an easily administered technique with a few contraindications for patients. The term inhalation sedation describes the induction of a state of conscious sedation by administering sub-anesthetic concentration of the gaseous anesthetic agents. So inhalation sedation is composed of oxygen and nitrous oxide gas. So we are making sure the patient's having this minimum nitrous oxide, minimum oxygen needed for his body, and the nitrous oxide to make him sedated. So the pharmacology of the nitrous oxide is a colorless and virtually odorless gas with a faint sweet smell. On inhalation of nitrous oxide to the lungs, it has a rapid uptake. That's very important information about the nitrous oxide. It has a very rapid uptake as it is quickly absorbed from the alveoli and is held in a simple solution in the serum. Nitrous oxide is rapidly excreted from the lungs. Once nitrous oxide is no longer being inhaled, then the nitrous oxide within the central nervous system will rapidly pass down the gradient into the bloodstream and out of the body via the lungs. So, as it has very fast induction and has very quick recovery. So once you have started with the nitrous oxide sedation, it has quick effect, and once you're done with your treatment or with your nitrous oxide sedation, the recovery is very quick as well because of its very rapid excretion. Okay, a very small amount of it is excreted in the body fluid. Nitrous oxide is 34 times more soluble in blood than nitrogen, and as a result of this, diffusion hypoxia, which I'm going to talk to you, that's diffusion hypoxia actually is one of the complications of the using nitrous oxide may occur. So because of the nitrous oxide is more soluble in the blood than the nitrogen, the diffusion hypoxia will occur. I'll explain to you in a bit. This is a reason for the importance of the administering 100% oxygen for 3 to 4 minutes to the patients once the nitrous oxide has been administered. So keep it in your mind to avoid any kind of diffusion hypoxia. Whenever you're using nitrous oxide sedation, to terminate your session with 3 to 5 minutes of giving pure oxygen to avoid there is any chance of diffusion hypoxia. Because in diffusion hypoxia, due to the solubility, the nitrous oxide being more soluble than the nitrogen, so there will be a temporary hypoxia, which is called diffusion hypoxia in the bloodstream. So giving pure, which is 100% of oxygen for 3 to 5 minutes, once you're done with your inhalation sedation, it's a very effective way to reduce these effects. Okay, so for whom we can use? So if you know the American Society of Anesthesiologists, which is ASA, the classification has 5 grades. Grade 1 to the grade 5. The grade 1 is the normal healthy patients, and grade 2 is the patient with mild systemic disease like a controlled diabetes, controlled asthmatic patients, and ASA 3, patient with severe systemic disease that is limiting but not incapacitating. That's mean like patients with uncontrolled diabetes, patients with severe cardiac problems, or in ASA 4, the patient is incapacitating disease that is a constant threat to the life. And unfortunately, I can say that in the ASA 5, patients not expecting to live more than 24 hours. So, for which kind of this ASA grading we can use nitrous oxide? For which of these ASA scales the nitrous oxide is safe to use? So here it says that only individuals in groups of ASA 1 and ASA 2 are suitable to receive the conscious sedation in the practice. Conscious is like a nitrous oxide. So basically these two, the ASA 1, ASA 2, which are the normal patient and patient with mild systemic disease, it's safe to use nitrous oxide sedation. Okay, so sedation appointments may take up to 45 minutes for quadrant dentistry. Therefore, the busy general dental practitioners, which is very common now to see in the private practice, need to ensure that the patient is willing to accept this form of sedation in order not to waste the valuable practice time. Okay, so let me explain to you. The sedation appointment usually takes time because of the procedure of the sedation itself. Because you need to wait for the sedation to work, and then you need to proceed with the local anesthesia, and then you need to proceed with your treatment, and then you need to wait for the recovery and give oxygen at the end of the sedation to reduce the diffusion hypoxia. So usually it takes around 45 to 50 minutes of your appointment time. And in the private practice, having an appointment for 50 minutes to 1 hour, it's not cost effective, I can say that, in the private practice. But the good way is that if you're practicing nitrous oxide sedation in your practice, always try to have an introduction appointment to the nitrous oxide in a visit before. That will save a lot of your time. For instance, if the patients come to you and patient is anxious and you decide to treat the patient under nitrous oxide sedation for extraction or for pulpotomy on the next visit, and you don't know exactly if the nitrous oxide sedation will work for this patient or not. In these cases, always try to have use the introduce the patient to the nitrous oxide, to the nasal mask, to the see how it takes for the child to breathe. Can he do that? Does he get more scared of having the nasal mask? And if you're sure that that will work with the patient, then give a schedule for the patient with at least 40 minutes of the treatment for the nitrous oxide for the dental visit. And I always suggest that try to have a rubber dam in place whenever you are having a nitrous oxide sedation. And that I will explain to you why we need to have a rubber dam when we go to the demonstration, and we'll have it on the machine itself. Let's go back to the article now. Oops. Okay, so yeah. So what are the indications of... Hello everyone who joined new, yeah. Okay, so what are the indications of the inhalation sedation? So indications for use of inhalation sedations are fear of and anxiety. Any patients come, patient is anxious, patient has a fever, or in the cases of the patient has a dental... Wait, I need to emphasize that. If a patient comes to you, even if you are not sure if the patient has an anxiety or no, usually in the first dental visits, or when it's the first patient's dental visit, patients come to you and it's an emergency and you don't know if the patient will cope with the treatment or not. And if the patients cope with the treatment, usually if the treatment The title of the paper is, sorry. Hello, someone is asking for the title of the paper. It's this one. Anyway, we are going to upload it. I don't know who was that, who asked that. Yeah. Faris, we are going to upload it so you can have it. So, okay, sorry for interruption. Yeah. So whenever you have a dental visit, it's your it is a patient's first dental visit, and you are not sure how cooperative is the child, and the patient needs further treatment, and you don't want to lose the patient's cooperativeness in the following the visits, then it's always suggested to use the inhalation sedation for the first dental visit, because that will give a good experience to the child about the first dental treatment, and patients usually come back with a better experience and better cooperation when they come for the next visit. So always when you have a patient, it's the first patient's dental visit, and you have a traumatic dental treatment by having like multiple extractions or doing a pulpotomy or pulpectomy. In these cases, then I always encourage you to use inhalation sedation for this kind of patients. That will save a lot of time or for future dental treatments, and it will save and you will save the patient, and you will have the patients to continue with its having a high cooperation level. Yes. So we were talking about the indications for the use of inhalation sedation. So we discussed about the fear and anxiety, needle phobia. Very profound local anesthesia cannot be obtained, like acute pulpitis. Why? Because don't forget that inhalation sedation is not only, it doesn't give you the sedation effect, it has some analgesia effect as well. So it will increase the depth of the anesthesia and decrease the need for local anesthesia. So if you are using inhalation sedation, there is some numbness in the soft tissue as well, plus that's the sedation that you are using. So if you are using inhalation sedation, then you need less anesthesia, and even sometimes you don't need to use topical if usually the soft tissue will be numb as well. But that's very mild, and keep in your mind, always when using inhalation sedation, you need to use local anesthesia. Local anesthesia is a must for the procedure if it's needed to use the local anesthesia. Okay. Sorry, I'm reading your comments. Yeah. So, gag reflex. It's very important because it gives some kind of numbness, as we said, in the soft tissue or in the oral soft tissue. So if the patient is gagging, it's very effective to use the nitrous oxide sedation. Hypoplastic teeth to decrease in sensitivity. That's when you have a molar incisor hypomineralization, if you are aware of this terminology. In case of you have hypomineralized molars and central incisors, because of the hypomineralized enamel discs, usually they are very sensitive to the brushing, sensitive to the air, sensitive to the water, and even with the giving local anesthesia, usually this might not go to the full anesthesia or analgesia. So always it is advisable to use sedation for this kind of teeth which are hypoplastic and they are very sensitive. Okay, so if in cases that you need prolonged or unpleasant treatment or surgical extractions, or as we said, if it's the first patient's dental visit, always it's advisable to use the inhalation sedation. Or patients with the persistent fainting, it is an alternative to general anesthesia for some special needs or medically compromised patients. Like if a patient comes to you, patients come with patient is autistic, mild autistic, like Asperger's syndrome. In these cases, especially in the Asperger's syndrome, which is a mild case of autism, usually the patients are not that uncooperative, and they do cooperate if you work with the tail show do and having a good cooperation and trust with the patient. So in these cases, the sedation is a substitute to the general anesthesia. So in many cases, you might exclude the option of general anesthesia by having the option of inhalation sedation with nitrous oxide. Okay, with the patients patients with cardiovascular disorder, it's because it reduces the anxiety and elevates the pain threshold and provides increased level of oxygen. So I'll give you another example. If the patient is asthmatic, and what a patient is asthmatic and anxious. Yeah, let's go back here. If the patient is asthmatic and anxious, it is highly recommended to use nitrous oxide sedation. Some might say that, okay, patient is asthmatic, do you use nitrous oxide? Won't it affect the inhalation? Won't it affect the respiratory system? I tell you, no, it will help a lot. Because it will reduce anxiety, first of all, because if you have less anxiety, it will affect if you have the anxious patients, they are more they have higher chance of getting the asthmatic attack if they are anxious, so you will reduce the chance of asthmatic attack. And at the same time, keep in your mind that with the nitrous oxide sedation, actually will give them more oxygen than they breathe in the air. If you know that okay, I'll give you a question. Give me answers. I want to see the answers here, please. What is the oxygen? How much of oxygen do we have in the air? Who can answer me, please? How much do we breathe oxygen from the air? Normal. Now I'm breathing, 3%. Try again. Try again, Mustafa. Okay, YW 21%, very close. 98, 20, close. Okay, so we don't waste the time. Thank you, everyone. Yeah, so unfortunately there is no prizes. I wish that there are some prizes. So the correct answer is it's around 20. Okay, yeah, those who answered around 20, yes, it's correct. It's around 20 to 25% we have oxygen in the air. So the one that so in the nitrous oxide, actually we are giving them the more oxygen than the air. Imagine that you are giving 30% when the rate of the nitrous oxide, because always we have rate between the nitrous oxide and we have a rate between the sedation. And so with the oxygen, so the nitrous oxide and sedation ratio, it could be usually it ranges from we'll start with 100% oxygen and then we'll go reduce it down to reach up to the minimum. I used to go for 50% oxygen and 50% nitrous oxide. So with the minimum nitrous oxide, the lowest level of the nitrous oxide that you will give, which is you give 50% of nitrous oxide and 50% of oxygen. At this point of still you have more oxygen than the air, so you are giving the patient more oxygen than the air. So even if you have a deep taking the child to the deep sedation, like 50% of nitrous oxide, still you are giving the child more oxygen than what is in the air. So it's quite safe to use nitrous oxide for this kind of the patients, because with the nitrous oxide you are going to give them more oxygen than what do they breathe in the air. Okay. Yes, so here is the continuation of the indications of the nitrous oxide. Sickle cell disease or triad of the severe asthma. With asthma we mentioned, same in the sickle cell disease, because if they have hypoxia, low level of the oxygen, there will be more destruction of the blood cells in case of sickle cell. So in these cases, if you use the nitrous oxide, it's quite safe. Why? Because as you mentioned, for asthma, we are giving as high as oxygen tension in the as maintained. So we are giving them the highest level of the oxygen that they need. In case of cerebral palsy, to control the athetoid and the kinetic movements, so that make them more relaxed, and we reduce the movements of the patient with cerebral palsy. So let's talk about the contraindications. I can tell you that there are no any absolute contraindication for nitrous oxide sedation. Most of the contraindications are relative contraindications in case of nitrous oxide. So you might be able to use it, but in some cases you might not be able to use the nitrous oxide, which we are going now to discuss about these contraindications. So the contraindications to relative analgesia with nitrous oxide oxygen sedation are only relative. So there are no any absolute contraindication to the nitrous oxide. Risk of giving the patient sedation against the risk of administering general anesthesia, that's a good point. So whatever, because since there is no any absolute contraindication with nitrous oxide, having the option of the nitrous oxide and comparing it with the general anesthesia, which already there are reported risk of the using general anesthesia for the patients, it's very beneficial. So I would use a nitrous oxide sedation for my child, and I will not use the general anesthesia for my child if it's not needed. And always keep in your mind. Oh, I'm very fast, Saud. Okay, I'll be slower. Yeah, sorry. Okay, so whenever you have, okay, it's very hard. I'll try that. Okay, how can I be slower? I wish the Instagram has this slow motion options. I keep it in the slow motion. I don't want to make myself a bit slower. Okay, so yeah, what I was talking, Mustafa, can you help me? What was the topic I was talking? Yeah. So yeah, Mustafa, he is here.
Alright.
Yeah, he's waiting for his first trial with the nitrous oxide. He's very keen and enthusiastic to use it. It's his first time trying the nitrous oxide. Yeah, if the patient is uncooperative patient, not count as the contraindications. Yes, actually we are using the nitrous oxide for uncooperative patients, but there are some contraindications or some situations that you don't need, that you should avoid using nitrous oxide, or you might not get the effect of the nitrous oxide in some patients, that especially those who are crying, because the a key of success of nitrous oxide is to have a sealed mouth and keep the patient breathe through the nose and do not exhale the nitrous oxide from the mouth. Okay, I'll try to be slower. Yeah, so the key is that to have the patient to breathe through the nose and not to exhale the nitrous oxide from the mouth. So in this, if the patient is crying, if the patient is moving and the patient is shouting, then in these cases it might not work. But in some patients, the patient is uncooperative, but they can maintain the sealed mouth and they breathe through the nose in 2 to 3 minutes of nitrous oxide. Once they exhale the nitrous oxide for 2 to 3 minutes, then you can have the effect of nitrous oxide there. So let's go back to the article, guys. Yeah. So the contraindications, we say that we'll come here now to the contraindications. Yeah. So the contraindications are, as we say, that these are all relative contraindications and not considered as absolute contraindications to the nitrous oxide sedation. So inability to communicate, that's very important to consider when you are using nitrous oxide for your patients. When do you need to consider that? If a patient is too young, 2 to 3 years old, can you communicate with your child, with the patient, with the 2 years old, 3 years old? I can tell you no. So if you cannot communicate with your patients and patient does not understand what's going on, how he's going to feel and experience the nitrous oxide, in this case the nitrous oxide unfortunately doesn't work. And that's why, as we said in the beginning, the option of the general anesthesia, sometimes it's unavoidable for a very young patients, because the nitrous oxide will not work for very young patients. Okay, the second contraindication, very young children. Why? Because they cannot communicate. So very young children, some authors also suggest not less than 6 years of age, but each case should be assessed on its own merits. Yeah. So the I'm sorry, I'm reading the comments. What about COPD. Okay, I'll come to that. Healthy cells, and I'll come to talk about that. Yeah, give me a few minutes. Yeah. So from our experience here in the Dubai Dental Clinic, which we use nitrous oxide sedation, we usually start from the age of 5, and in some cases which are emergency, and if we feel the patient has good communication and good understanding of the situation, we might use it for like 4.5 and 5 years old. But as they here in the guideline we read in the article, we read the best ages to start is from the age of 6. Why? Because you need to have good communication with your patients while you're treating the child, and they need to understand what's going on. And some patients might have the fear of the mask, so they don't let you to keep the mask and all the time in the nose. And that's what we said, the key of success of nitrous oxide sedation is that they need to breathe through the nose, and they don't need to exhale the nitrous oxide through the mouth. So, and that's the complementary comment, that they need to be mouth breathing. So if the patient is, they should need to be breathe through the nose and not through the mouth. If the patient is mouth breathing, then you cannot have successful sedation. Or if the patient is unwilling or unable to nose breathe. So in these cases, a patient cannot breathe through the nose, blocked nose, upper respiratory tract infection, or adenoids, or whatever the reason of the ENT problems, the patient is mouth breather, then the nitrous oxide is out of your box of options. As we say, cold and rhinitis. Why? Because in these patients they don't have patent nose, so in these cases you cannot use any kind of sedation, nitrous oxide inhalation sedation. Chronic obstructive airway disease, again, is the same, because why? They cannot breathe through the nose and they breathe through the mouth, through their mouth. Otitis media, because of the nitrous oxide, causes pressure volume effect on the ear, and that's one of the complications I'm going to talk about in a bit. And severe muscular depression activity, like multiple sclerosis, severe psychiatric disorders because of the medications they take, usually the antidepressant medications, behavioral and personality problems, and learning difficulties. If the patient, because the patient need to understand what's going on, what's the technique, and what's the they need to get you, they understand the feeling that they feel with nitrous oxide sedation, and we need to have a communication with your child. So I'm using a lot of the word of child, but I mean the child. Your child means your patient, which is your child patient. Yeah. Learning difficulties, same, because they need to understand this the technique. Psychological or loss of control, and this is it's mainly for the adults or for the doctors or for the practitioners, or for the anyone who's using the nitrous oxide. To be in a safe side, don't use, if you are in the first trimester of pregnancy, don't use inhalation sedation. Otherwise, consult with your physician. I don't go into that detail. So here you can see the mask. I'm going to show them to you in a bit. Okay, so here it's the technique. Here they talked about the technique. I'm not going to read about the technique. I don't want it to be boring to you. I'm going to show it to you in the action. So I just need to show you this paragraph. At the level of nitrous oxide oxygen, or nitrous oxide oxygen inhalation sedation, or in the other word, can be the level of nitrous oxide can be increased in 5 to 10% increments until the signs of sedation are observed. So we'll start with 100% of oxygen, and then we'll reduce the nitrous oxide in increments 5% or 10% until we see the signs of sedation. Then the endpoint will vary, the common range being between the 30% to 50% of nitrous oxide. The level of the nitrous oxide, or until where you go, it's all depend on the how much of sedation you need to have with your patient, or what is the procedure you are doing, or at which level of procedure you are. Why do I'm saying that which level of procedure? Because I do usually, if you see while I'm doing the inhalation sedation, I'll be my highest level of highest proportion of the nitrous oxide that I'll give usually is before giving local anesthesia. So once I give local anesthesia, I will increase the oxygen level and reduce the inhalation and nitrous oxide level, because that's the time you need to have the patient to be more cooperative and have the best experience. Because once you anesthetize the tooth, then the patient won't feel anything, and you can work with the nitrous oxide sedation of the 70% of oxygen and only 30% of the oxygen of the nitrous oxide. So 30% of nitrous oxide and 70% of the oxygen. It's usually my rate of nitrous oxide while I'm doing my treatment. But during local anesthesia, sometimes I will need to go much more down, like reach like 40%, or in very, very severe, rare cases, I might give 50%, but only for a short time during giving local anesthesia. And once I give my local anesthesia, patient is numb, then I'll increase the local anesthesia level. So above 40% nitrous oxide concentration, the increase of nausea and vomiting, the incidence of nausea and vomiting increase, and therefore should only be used by an experienced operator. Higher level are used for resistant patients or where there are no other alternatives. So I use only if I see my patient is very uncooperative. In that cases, I will reduce the oxygen, increase the nitrous oxide, but that will be for a very short time during giving the local anesthesia, and then I'll go back with the high level of oxygen and lower level of nitrous oxide. Because the issue is that it might cause, if you go very deep, it might cause nausea, and sometimes if the patients came with a full stomach, it might cause vomiting. But I'll give you some clinical hints how to reduce that. Okay, let's review this table now. So when you are giving inhalation sedation, so what are the signs and symptoms of early to ideal sedation with nitrous oxide and oxygen? So the signs of when you are giving the signs of the sedation, or how do you know the patient is sedated? So the signs are blood pressure, heart rate is slightly elevated early in the procedure and then returns to the baseline values. Respiratory normal and smooth, so it won't affect the respiration. It will cause peripheral vasodilation and flushing of extremities and face. Decreased muscle tone as an anxiety decrease, and arms and legs they get relaxed. So these are the signs of the normal sedation or ideal sedation. Let's go to the symptoms now. Okay, when you have the symptoms sometimes could be lightheadedness, headedness or dizziness, or tingling of the hands and feet. That's very common. Most of the children, they feel that, and usually how do you know that? They start off itching the teeth, and they play with their fingers and hands. They play with their hands, and that's the sign to give you that they are having tingling of their hands and feet. Wave of warmth, feeling of vibration throughout the body, numbness of the hands and feet, and that's the symptom. This is a symptom that I'll tell you initially that although it's called inhalation sedation, it has some analgesic effect, and that's why it will cause numbness of the hands and feet, and sometimes it will cause numbness of the oral mucosa and soft tissue as well. So numbness of the soft tissue of the oral cavity, feeling of euphoria, analgesia, feeling of lightness of extremities. So now what are the signs of heavier or slight over sedation? just keep in your mind, sometimes your sedation might be it will go to the deep sedation. So what are the signs of deep sedation? If the patient has increased movement, so although they are too down in the level of the nitrous oxide, you reach up to, for sometimes you reach to 50 or nitrous or 40% of nitrous, and you see the patient is increased in the movement, that's a sign of our sedation, and then you need to start increasing the oxygen level, or increase heart rate and blood pressure, increase rate of respiration, increase sweating, and possible lacrimation. Okay, what are the symptoms? Okay, hope you read it now. Okay, just flip your phones, please. Yeah, the symptoms are in hearing, especially of this also. Just keep it's in your mind that we're talking about the heavier or slight over sedation here. So we have hearing, especially of distant sounds, become more acute. Visual images become confused. Patterns on the hearing being to move. Sleepiness and sweating increases. The laughing or crying. Make sure that they don't exhale the nitrous oxide gas out while they are laughing or crying, and at this stage you need to control the level of the nitrous oxide that you are giving to maintain it throughout your treatment. Otherwise the patient will turn to be uncooperative. Why? Because the patient has exhaled all the nitrous oxide by breathing through the mouth, and they might have dreaming, and they might have, at very deep sedation, they have nausea. Okay. So, for the patient discharge, so once you are done with your nitrous oxide sedation visit, what do you need to do with the nitrous oxide machine, or in the other word, what is the last step of nitrous oxide inhalation sedation before dismissing the patient? So, when you're before patient discharge, on termination, we need, as we said, we need to give 100% of oxygen. So we need to give 100% of oxygen to allow the patient to sit upright, and allow the patient to sit upright in the dental chair for a few minutes. This to combat any postural hypotension. And also verbal and written post-operative instructions should be given. So why do we need to give 100% of oxygen? You guys remember, initially we said that one of the complications of the nitrous oxide is diffusion hypoxia because of the higher solubility of the nitrous oxide. So there will be a high temporary diffusion hypoxia, and by giving 100% of oxygen for 3 to 5 minutes after the termination of your treatment, and making the patient slightly upright, that will reduce the chance of diffusion hypoxia. So, advantage of inhalation sedation: it's non-invasive, drug level may be easily be altered or disconnected, and titration is very easy by giving 100% of oxygen, and rapidly absorb, and rapid onset within 2 to 3 minutes. It's quick onset and quick recovery, rapidly eliminated from the body, and rapid and complete recovery within 5 minutes, while it will increase if you give 5 minutes of 100% oxygen. Minimal impairment of any reflexes, so that's protecting the cough reflex. This is but we don't have this when the patient is in general anesthesia. We don't have any reflexes. Some analgesia is produced and may therefore be useful to supplement the topical anesthesia for needle phobics. That's a very important point to remember, because keep it in your mind that the patients might have some analgesic effect, plus the local anesthesia that you are giving. That also will help to profound your local anesthesia. Injections are not involved in the administrations of the sedation, so it is a useful technique for needle phobics. Why? Because we are using only the mask and the nasal mask to administer the nitrous oxide, and we are not doing any IV or intramuscular sedation in these cases. So disadvantage, actually I don't want to talk about disadvantage because I like it, so I don't want to make you hate it. So let's talk about it. So it has lack of potency, dependent largely on psychological reassurance. So if you tried it once, you want to try it for the second time, then you want to try it for the third time. So it has dependent largely on the patient with psychological reassurance. Gas must be administered continuously via a mask close to the operation site. So keep in your mind, the mouth should be closed all the time, and patient needs to breathe through the nose. Otherwise, the effect will be very low. So nasal hood may be interfere with the injection in the anterior maxillary region. That's not a big deal. We can manage that. Patient must be able to nose breathe, and nasal hood may be rejected by some patients. So let's quickly talk about now the adverse effects in for 1 minute, and then we'll go for the demonstration. So diffusion hypoxia, as we said, diffusion hypoxia can occur as a result of the rapid release of nitrous oxide from the bloodstream into the alveoli, so diluting the concentration of the oxygen. This will lead to the headache and disorientation. However, it can be avoided by delivering the 100% of oxygen for 3 to 5 minutes. We discussed that. The others are nausea and vomiting and pressure volume effect, which affect the pressure volume effect of the nitrous oxide. It affects usually the middle ear. And nausea and vomiting, I can tell you how to avoid that. Usually don't go so deep in the nitrous oxide. And the other way of reducing the complication of nausea and vomiting, try to have a constant level of local sedation throughout your procedure. Do not have fluctuation of the nitrous oxide, so don't increase rapidly and don't reduce rapidly. And other way of having fluctuation in the nitrous oxide, in case that patient is mouth breather. For example, if you want to use the nitrous oxide for extraction and you cannot use the rubber dam in this case, so the patient will keep on. Yeah, the patient will keep on. Sorry, they put some note for me here. Let me read it. Okay, they say that the video might stop in 3 to 4 minutes. Okay, so what we will do, we'll stop this video and then we will restart it again, and we'll show you the demonstration of the nitrous oxide sedation. So I was talking about how to reduce that, nausea and vomiting. Don't keep the patient breathe through the mouth constantly, through the nose, constantly without breathing, exhaling out the nitrous oxide from the mouth, and do not have fluctuation during your nitrous oxide procedure. That will reduce the patient nausea. And advise the patient not to have a very heavy meal before the treatment for 2 hours. That also will reduce the nausea and vomiting during sedation. So I think we'll pause the video, or we'll close it, and then we will start it again. This is the policy of the I don't know, they told me we have a director there. He's telling me please stop. So I'm going to stop now, and we'll get back to you in a few 1 to 2 minutes with a demonstration of the oral or inhalation sedation with nitrous oxide. Stay tuned, we'll get back. How can I stop that, director? So welcome back. Shall we wait, or everyone is there now? Okay, so yes, this is the portable inhalation sedation machine. Okay, I'll tell you, we have either it's portable or it's built in the wall. So we have here the nitrous oxide and oxygen is built in the wall, but I'm going to show it to you now, which is the portable machine. So okay, so this machine, it has a control panel here, so you control it, and then you have the 2 cylinders. One is backup cylinder, and one which is in use. So usually we have in use, and we have one full for a backup in case that it gets finished during the treatment. Whenever you're using the in-use cylinder, then you can have a backup. Same we have for the nitrous oxide cylinder. We have the in-use one, and we have a backup full cylinder. Okay. So basically, we have different sizes and different flavors of the nitrous oxide. It has different smells. So this one is plain, so basically with almost with no smell with the this is the bubble gum. So when they have the when they inhale the nitrous oxide gas, they smell the bubble gum. We have the different flavors with different sizes. It comes in medium size, moderate, small, medium, and large size. So according to the age of the patient, you usually need to use either of them. So other than that, we have this bag. This will show us how the patient is breathing and how much is the flow rate. So if the flow rate is too low, then it gets exhaled. Or if the patient is not inhaling, then it gets inflated. So this will give you the indication how the patient is breathing, and it give you the indication how you need to adjust or change the flow rate of the machine. So I'm going to turn it on, and always keep in your mind that it needs to be always connected with your high volume nitrous oxide. The nitrous oxide will need to be connected with the high volume suction, just to as a scavenging machine. So we need to exhale the always this needs to be connected to the high volume suction, and you should turn it a bit on. Don't turn it fully when you are using, because it will exhale the most of the gases out, and less for the patient to breathe. And we'll keep it open less than half. Okay, so we'll leave it here now. This is the gas. Okay, we have our my dear friend, Mustafa. He's watching live there. Okay, Mustafa, concentrate with me. Yeah. Mustafa is our first year pediatric dentistry resident. He has been using the nitrous oxide for his patients, but he has never used it or tried it on himself, right?
Yes,
so are you ready to use it?
Yes, I am.
Okay, are you scared?
No, not really.
Yeah. Unfortunately, he's not scared, but in real life, usually we use it for scared or with a bit anxious patients. So we are going to try it. So I'm going basically to show you how this will work and how the nitrous oxide is. So I'm going to turn on the oxygen cylinder and the nitrous oxide cylinder, and then I'm going to turn on the control panel. Yeah. So we have selected the large size of nasal valve for our dear friend Mustafa. Yeah. And here in the control panel, you can see that this is the percentage of the oxygen. If you come closer, please. Yeah. Here you can see the percentage of the oxygen that's giving. So usually we concentrate on the level of the oxygen. So to start with 100 and then it reduces. For example, when it reaches 90, it means that it's 10% of nitrous oxide and 90% of oxygen. So now we have 100% of oxygen. It's giving this mass. And here we have the flow rate. This flow rate shows that how much of the air is going to the mask. Sometimes we need to increase or decrease. And we have the oxygen flush. This we use it in case of emergency, and when we need to give 100% of the oxygen to the patient, then we have this bottom, we use it oxygen flush, which gives 100% of oxygen. See, when I press the oxygen flush, the oxygen flush, how it gets deflated. So, yeah, this is the normal. Okay, so this is how we are using the nitrous oxide. Okay. So there's a question. What if it's above 100? We don't have maximum oxygen that we can give. It's 100. The question that was asked, what if we go above 100? Maximum oxygen that we can give is 100. And the minimum oxygen which is built in the machine, that's why it's always safe to use. The minimum oxygen that usually we give, it is set in the machine, it is 30%. So the oxygen will never ever go below the 30%, which is above the normal oxygen level which is in the air. So because in the air it's in 20s, so when you have the using nitrous oxide, it's reached around 30%. So it's 30%. It's more oxygen than it should be in the air. So it's very safe because the oxygen level in the nitrous oxide that we are using, it's always more than the air. And if I try, it will never go below 30, and its minimum oxygen that I can give is 30%, and the maximum nitrous oxide that I can give is also 30%. So I'm going to try it now on Mustafa. Yeah. So yes. Can you just remove your glasses, please? Okay. Just keep in your mind, whenever you are using inhalation sedation, have a very calm room, because the patients need to feel calm and avoid any noises. Close the door of your clinic and avoid any interruptions or any extra noises, because if you want to have a very calm atmosphere and environment, so the patient will feel very comfortable and calm during the treatment. So first I'm going to ask, I should have asked him before that if he has a patent nose. Do you have a patent nose?
Yes, I do.
Okay, can you breathe through your nose? Yes. So that's the first sign that I can do my nitrous oxide sedation on him, because he can breathe through his nose. And the other thing that always, if you can see in our clinic, we have 2 monitors. This monitor is when we use it when the patients need to look forward and see the patient. The top monitor now, that is built in to use. We use like a cartoon to distract the child, to make him look at something else. So it's good for distraction to have a monitor and put the cartoon that they would like to watch, and at the same time they look up. So look what will happen if I have the mask. So make sure it's well sealed, and we need to tighten it from the bottom, from here. So it's well sealed. We need to, okay. Always have your mask, otherwise me as a technician or doctor, I'll get sedated with my patient, both of us will go to sleep. So I should have always my mask there, so otherwise, because always there is some leakage around, and still now for now we have 100% of oxygen. But once I start, I need to make sure that I have my mask, otherwise I will get sedated and both of us will go to a deep sleep for 2 nights, right? Yeah, so don't sleep for that. Okay, so now the issue is that when I have this mask, patient cannot look at this monitor which is in front of him. Maybe if you can take from the back with you. If now he cannot see this monitor, so always, yeah. So when we have the mask there, patient cannot look forward, and always it's good to have a monitor on the roof, so the patient will look on top, and this mask will not interfere with the distraction, with the video or cartoon that you are putting, that will help. Okay, so I will start always with 100% oxygen. I'll train him. Okay, breathe through your nose, okay? Keep your mouth closed, breathe through your nose, and take normal breath, okay? Just breathe normally and breathe through your nose, okay? And make sure it's tight enough. It shouldn't be very tight. Sometimes it's annoying and patients try to move, and it shouldn't be loose that it leaks from the side. Okay, so I'm going now to reduce the oxygen level from 100% level of oxygen. Yeah, okay, yeah. So our director is very busy behind the scenes. Okay, well done. Okay, so I'm going to reduce the nitrous oxide sedation now from 100%. I'm reducing the oxygen, so I go down 10%. So I'm giving now 90% of oxygen and 10% of nitrous oxide. So having 10% of nitrous oxide, that's a good to start for 2 minutes and then reduce the nitrous oxide every 2 minutes or 3 minutes. Slowly will go down until we feel signs of sedation. Okay. At this level, I'll make sure the patient is breathing through the nose. He is calm. I'll reassure him. I'll call him. Sometimes if you give them, tell them some stories that you might feel that you're flying. You might feel it because they feel lightness. So they might. It's nice to tell them that you might see you're floating on the clouds. You might see some birds. So he's big enough now for these stories. But just tell us whatever feeling that you start with. Okay? I know I'm very noisy and talking, and I should be a bit more calm and less so he gets more relaxed, but it's a trial. Yeah. So, whenever I'm doing the sedation, I'll always keep my eyes on this bag because it gives me an indication of what's the flow rate I have to do. Now, for now, my flow rate is 5.0, so I'm happy with my saturation. So I stay with this level, just to see how it's reduced if I keep it 4. So if I'm going to keep it 4, get the flesh a bit, and the rate of the flow rate will reduce. So I'll keep it for now for 40. And I'll reduce it now to 80% oxygen, and we have now 20% of nitrous oxide. Just keep breathing through your nose and feel relaxed. You might feel now once I go down more reach around 80 to 50, he start to feel a bit tingling in his hands and fingers. So I'll let him to tell us what does he feel. Breathe, breathe. Any questions? Okay. Take a deep breath. Every minute I'll ask them to take a deep breath. Take a deep breath. Another. When they take a deep breath, I can see the effect of inflating and inflating of the bag here. So it's very nice to see if the nose is patent, if he's breathing or not, or he's... Are you sleeping? What do you feel now? Okay, how much time it takes for a patient to be sedated? The time depends on the patient itself. If the patient is he's very cooperative, like our friend Mustafa, he's very cooperative. It takes keep it in your mind. Every 2 to 3 minutes, you need to reduce 10%, and then once you reach 70% oxygen, then every 5% you need to reduce. Every 2 minutes you need to reduce 5%, because we are reduced every 10 for initially. So here it means that he is sleeping. So it depends on the patient. Some patients it might take around 5 to 8 minutes, and maximum it shouldn't usually take more than 10 minutes for a patient to get sedated. What do you feel now, Mustafa? If you don't have anything, don't exhale the nitrous oxide out. You okay? You feeling comfortable? Okay. I always ask especially if you don't have the monitor on the top, and they try to watch the monitor, they keep on tilting the chin down. So that will make the airway very constricted. So I'll always ask them to have the chin up. That will make the process of breathing faster. So again, I keep on watching my bag and making sure the flow rate is good. I reduce it now, more 10. Sometimes after 80, I reduce 5%, but in this case, I'll go for, for the sake of demonstration, I'll go for 70. Every and then just make sure that there is no leakage, because sometimes when you tighten it from the other side that you don't see, you might see that there is a leakage or it's pulled out. So there is a question. Okay. If I'm dealing with an adult, how this make the okay? Would this make the time for sedation longer, or would the rate of the lowering the concentration lower? I can tell you it doesn't have any having a child or having an adult. It doesn't have any doesn't make any difference. So the only difference is that if the patient is cooperative, if the child is cooperative, like we have an adult now, do you use pulse oxidizer during? No, for nitrous oxide we don't need to use that. Pulse oximeter we don't need to use for the nitrous oxide. If I'm using inhalation sedation or am I using IV or intramuscular sedation, then I need to use the pulse oximeter. Otherwise, for the monitoring the inhalation sedation with nitrous oxide, I just need to see the patient's breathing well and flow rate is enough, and we have good communication throughout the procedure. Then it's fine. It seems that he's sleepy now. How do you feel?
No.
Huh? Do you feel now? Okay, our friend Mustafa is feeling now. What do you feel now? He's sedated now. He's sedated. So where do you feel now?
It's like the hands.
So you feel that your hands and legs are numb. What about your oral cavity? Is it funny? It's normal. Okay. So he's not feeling any numbness in his oral mucosa. He starts just to feel numbness and tingling in his hands. That's the sign of sedation. Okay. Can a patient be allergic to nitrous oxide sedation? No, because we have this normal gas, and from my knowledge, I don't know any contraindication with the nitrous oxide gas itself. So there are no any there are no any allergies with the nitrous oxide using nitrous oxide sedation. Our friend is going to sleep now. You sleepy? Yeah. Okay. We need to make sure that someone will drive. Are you driving today? Okay, with an adult, always keep in your mind that someone else is there to drive them back to home. I think I need to drive Mustafa back home today. Right? Okay. Okay, we have another question. Your patient selection is based on what? Because we know that not all post a candidate for further nitrous. Patient selection, if I have a patient who can communicate, one patient is anxious and apprehensive, but I'm sure that the nitrous oxide will work on him, and will reduce the anxiety with the nitrous oxide. I'll use any anxious or any patient which he has few, 65. We are now on 65%, so any patient he is anxious and he has a phobia from needle, or if the procedure is very traumatic or very extensive procedure, and I want to give a good experience to the patient, definitely for this kind of patients, I'll go for using nitrous oxide sedation. Sometimes I'll get referral from the orthodontist, which they ask for extraction of the 4 premolars. In some cases, I might do extraction of the 2 premolars on the one side. In these cases, giving 2 local anesthesia, and I consider very extensive and traumatic procedure. So in these cases, what I do, I use nitrous oxide sedation to give a better experience to the child. So Mustafa, what do you feel now? How do you feel it?
I feel that every time you reduce it, I feel there's a difference in pain. There's a change.
So he's telling that with every reduction in the nitrous oxygen level and increasing the nitrous oxide, he feels a difference. Can you tell me what is the difference?
To be honest, I'm resisting the difference. If I don't resist, I will get sedated.
Okay, so he's trying to resist it, otherwise he will go to sleep. So please don't sleep. We need you for now, and I'm not willing to drive you back home, so you need to drive, okay? Okay. So Uh, yeah, we have another question. The length of the procedure is advised maximum for 5 minutes. Why? Because having the, don't sleep, Mustafa. Yeah. I'm making sure that it doesn't go to the deepest sleep. Okay, they suggested that to be 4 or 5 minutes. Why? Because if you have a lengthy procedure, it might go to the, it might cause nausea and vomiting if you have sedation for a very long time, because definitely there will be fluctuation during the procedure. And if you have the rubber dam in place and you are sure that you don't have the patient is breathing only through the nose and not through the mouth, then you might go ahead for like 50 minutes, maximum to 1 hour. But having a long sedation, it will affect the child and it doesn't have any long-term effect, but the patient will go to a deeper and a chance of having complications will increase. But usually for children, having a very lengthy procedure, more than 1 hour, it's very tiring for the children. So for children, usually it's preferable to have. Okay, so someone is telling me to let him try the nitrous oxide for 70%. I was expecting him to laugh, but so the effect is different in different people. Some people like me, when I tried, I laughed that they closed 4 doors behind me, so no one does hear I'm laughing. But he's very calm guy, although in reality, he's very active boy, mashallah, and he keeps on laughing all the time. So I found a way to make him calm, that to have him sedated. Anas, can you reach 80% as new studies? 80% of the oxygen of the nitrous oxide? Zainab, no, I cannot go to the 80% of the nitrous oxide. The machine has said that maximum nitrous oxide that I can give is 70% and minimum of 30% oxygen I should have. As you requested, I'll go down. Let's accept this challenge. Mustafa, you ready? I'm going now 60. Take a deep breath, breathe through your nose. What changes happen to you now? What changes happen?
More numbness.
More numbness. Any numbness around the face, the oral cavity? No. Okay. Nothing, yeah, right?
A bit. Now I do, yeah.
Okay, now he's feeling some numbness. That's the analgesic effect of the, don't sleep, Mustafa. Keep your eyes open all the time. So that's the analgesic effect of the nitrous oxide. So he's start to feel numbness around his face and his extremities, hands and fingers are numb. So I shouldn't go, I think I shouldn't go down, right? So
it's very relaxing.
Is it? So you like that? So do you want to try it for one more time?
Yeah.
Do you want to have it before each exam?
Definitely.
Definitely.
During
the exam, unfortunately you cannot have it. So that's it. It's very, people get addicted to the nitrous oxide, and it has been reported that many dentists, they get addicted to the nitrous oxide and they use it for themselves.
I will get addicted.
Please no, I will not let you to get addicted to the nitrous oxide. Okay? So when you start to get addicted, I should make sure that I lock the door every day after the clinic. Otherwise, when I come and see him, he is using the nitrous oxide. Okay. Make sure that he's breathing through the nose, mouth is closed. Make sure the head, chin is a bit up. So he's breathing well. How do you feel now? Let me tell you that in the patient, those who are sleepy already, okay, if I like in a patient that comes at the very end of the day, like at this time, 8 o'clock, 9 o'clock, which the patient is already sleepy, using the nitrous oxide, make them relax, and they'll have a really tight sleep. And that's because of they are already sleepy, but by having a little bit of calmness, this he went to sleep now. Okay. Well, by having this nitrous oxide, they feel very relaxed and calm, and then they sleep. So sometimes you need to differentiate between the deep sedation. Is it funny? Huh? Why?
Yeah.
Okay, you should close your mouth. So that's just laughing because it's called the laughing gas. Why are you laughing? Is it funny? Is it funny? It's not. Okay, yeah. Okay, you want to laugh? I'm afraid that he's exhaled all the nitrous oxide. Okay, we have another question. At which stage of at which stage of sedation should we start our procedure? Yeah, the stage of procedure. Stop. He's deep sedated. When the patient starts to when the patient starts to laugh, that's when he's deep sedated. So I'll increase it now. It's enough to be in a 60% oxygen and 40%. Sorry, I'm just sealing the lid so he doesn't exhale the gas now. So I'll keep it now 70. Try to close your mouth, okay? Everyone is watching you. Stop. Okay. You're exhaling, I'm afraid I'll get sedated. It's exhaling out the nitrous oxide out. Yeah, the level of the sedation, if I see now I increase it to 70%, he's supposed to stop laughing by now. Okay, Mustafa, close your mouth now. Okay, please close your mouth, yeah. So level of sedation depends on the procedure I'm giving. Usually the 60% oxygen, which is 40% 40% nitrous, I give it for the giving local anesthesia because even the director behind the phone is laughing. I think he is sedated, although I gave him the mask. He has a mask there. Okay, please, you will sedate everyone. Okay, we have another question. How can I work in a... Yeah, that's the problem. If the patient is laughing, we cannot work. That's why. So whenever the patient, see, you don't want to laugh now, right? Yeah, because I increase the sedation now to 70%, he's not laughing because because he was a bit in a deep sedation, so he was laughing. Now I increase it to 70%, he's not laughing. The patient should not laugh or cry. Why? Because the patient will exhale the nitrous oxide out from the mouth. We don't want the nitrous oxide to get out of the mouth by laughing or crying. So we need to make sure that the patient is breathing through the nose only. So that's why I increased the nitrous oxide now. So patient is now in the calm state. He's not deep sedated because the audience asked me to keep him deep sedated. I deep sedated him, but now he's back to normal sedation, which is 70% of oxygen and 30% of nitrous oxide. He's back to the calmness level. He's now calm. At this stage, I can work. I might give also back to the previous question.
I feel like generalized numbness.
He is feeling generalized numbness. So once the procedure continues, the numbness effect or the anesthesia effect will increase. So that's why I only reduce it to 60, or in very rare cases when the patient is very apprehensive, I reduce it to 50% oxygen and 50% of the nitrous oxide when I want to give my local anesthesia. So once I give the local anesthesia and the patient is numb, for example, I'm doing a pulpotomy, I put the rubber dam, always use the rubber dam because, open your mouth, yeah. If you don't have a rubber, so other than the other advantage of a rubber dam or having a good seal, no any like moisture or contamination with the saliva, having moisture control with the rubber dam. Other reason of using the must of using rubber dam in cases that you can use with the nitrous oxide, because the rubber dam will give you a sealing of the mouth, and only patient will breathe through the nose. So although the patient mouth is open during the procedure, patient will exhale the nitrous oxide. Patient won't exhale the nitrous oxide because the rubber dam is there in the place, and the patient will only breathe, inhale and exhale through the nose. So after giving my local anesthesia, I usually keep my sedation effect on the 70% oxygen, and I work. And once I'm done with my treatment, you okay now? I'll give you, will make you take it now to the recovery. Okay? So imagine now he's feeling numbness and tingling. So imagine now we have done with our procedure. Okay, once we are done with our procedure, now we don't need to go up to the 100% of oxygen incrementally. So once I'm done, I'll go directly to the 100% oxygen, because I don't want him to take any nitrous oxide. So I let him to breathe for 3 to 5 minutes of only oxygen without any nitrous. So that will exhale all the nitrous from the lungs, and patient will get recovered, get back to the normal, and we make sure that someone will drive you back home. Okay? So other things that usually I monitor during the patient, especially when I'm reducing the nitrous oxide to 50 or 40. I always have my hand on my other hand on the stomach of the patient, because if the patient, especially when I'm not using the rubber dam, when I'm using the inhalation sedation for the extraction, then I'll always try either monitor or have slightly just put your hand on the stomach, because before when they get this nausea and vomiting, you will see this stomach is going up and down, and they give you that the signs of patients having nausea and might vomit. So in that cases, when I see the patient having stomach is irritated and patient has nausea and tries to vomit, in that case I increase my oxygen level and reduce the nitrous oxide, because usually you will have that when the sedation is deep or there is fluctuation in the level of nitrous oxide. Let's go back to the, okay, if the patient is a smoker, would this have an effect? If the patient is a smoker, it might not have a direct effect on the nitrous oxide as long as they have the patent nose, because from my knowledge, I don't think that the smoking will have any, because the nitrous oxide is nothing different than the normal air. So if a patient can breathe normally through the nose, whatever we have the gases in the air, he can breathe and get the effect of nitrous oxide, even if the patient is a smoker, have the effect of nitrous oxide. So I'm almost done with 1 to 2 minutes of giving pure oxygen, 100% of oxygen. He's back to normal now, right?
Yeah.
Do you feel still tingling?
Little bit.
Little bit, okay. What is the reason of laughing simulation? Is it a reaction simulated in the brain sensory? Yes. So that's what they call it, laughing gas. And it's very common to have, it depends on the personality actually. Some they might laugh and some they might not laugh. So it's not must in every patient that you need to see laughing. He's back now, he's checking his tweets.
I'm laughing at the people's comments.
Oh yeah, he's laughing at the people's comments. Yeah, okay. My patient with a history of with vagal syncope. Okay. Is nitrous safe to use for hair? Yes, it is safe to use if the patient has vagal syncope. It is safe to use. Can we do both IV sedation with the inhaled gas? It is possible, but the patient, if you're using IV, with the IV sedation, you will take the charge of the deep sedation, and then there is no point of using inhalation sedation. So if you have the IV sedation, then you don't need to use the inhalation sedation. Other alternatives, which is old and it's not being practiced, they give still you are sedated, don't be active. Okay, in all the schools they used to give midazolam, oral midazolam, or like oral antidepressant for the patients before sedation. So when the patient comes to you is already sleeping, so they used to give oral plus inhalation sedation. But that's not anymore being practiced unless you are in the hospital setting, because there is chance that the patient go to the deep sedation, and in that cases recovery needs a hospital setting or a setting that you need to have IV sedation. So okay, so we'll discuss about the inhalation sedation. We have IV sedation as well in our clinic here. So for adults, usually we use it for adults who are adults or adolescents who are very apprehensive and we might go for IV or intravascular sedation if the option of the nitrous oxide sedation is out of the question. Okay, so I give him now 3 to 4 minutes almost now of oxygen. Are you back to normal now? Do you have your sensation back?
Alright, these 2 fingers of it.
Okay, do it safely. But do you have any dizziness? Do you have any headache? Okay, these questions you need to ask the patient. Okay, I'll give him a bit more now upright. Okay, I will make the chair a bit more upright. Yes. So I'll give him for 1 more minute because he was deeply sedated. Actually, he's not sedated, but he's laughing from your comments. Yeah. So, because I took him to deep sedation, so I'll wait for 1 more minute of the oxygen. Okay, how long should you give an O2 flush? Usually 3 to 5 minutes you give, and you ask the patient if he's feeling normal. And if the patient during sedation tells you that he has a tingling or numbness, just make sure that at the end of before dismissing the patient, the sensation is back. So usually 3 to 5 minutes is enough of giving 100% oxygen, and then the patient will be back to normal. For children, what post-operative instructions we need to give? We need to make sure that the patient is escorted with the parent or with an adult, and usually we suggest that the patients have less activities on that day. So less activities, and patients might go home, feel sleepy, they might sleep, and they should have a bit relaxed day than having a very active day. Are you okay now? Back? So I'm going to switch off the nitrous oxide machine now. We give him a flow rate of 4 or 100% of oxygen. He's back to normal, so I'm going to terminate it. He's back, okay? So, thank you so much.
You're welcome.
Okay, can you tell us about your experience? How did it start and how did it end?
So, by the way, when you were asking me questions, I was trying to say the answer, but the words were not, I wasn't able to fix the words properly. I had the answer in mind, but I wasn't able to tell you the answer.
Okay.
Anyways, but I was very fully aware. I was fully aware.
So the patient will stay conscious. Patient will not feel the patient will stay conscious. Yeah. So
I was fully aware. It started with the tingling and the proximities. The word I wanted to say is the proximities, but it was not coming out.
Okay.
Okay, and also like all proximities, fingers, legs, feet, and then after that, I used to feel the difference in every stage.
Yeah.
Like every time you used to change the concentration of nitrous, I used to feel that there's a huge difference.
Yeah.
And even when you adjusted the flow rate, I felt the the pull of.
With which one you were more comfortable? With having a high flow rate or low
I
flow
was
rate?
more comfortable with the higher flow rate. The older, the one before.
Yeah, it was 5 actually, so then we
Before, I thought that I was breathing like less gas. Yeah. Otherwise, at the beginning, I felt that the oxygen was more. I mean, the gas itself was more.
What would be considered as severe hypoxia? Severe hypoxia means during the procedure?
There would be no hypoxia.
I think
we're getting oxygen.
Just clarify your question, please. Okay, and
so I started feeling the numbness and tingling, but the oral numbness came the last. Like it was the last. The last numbness that has happened.
So he had some analgesic effect of the nitrous oxide. He felt some numbness in the oral cavity, in the mucosa, and so that's why it helps you. It profound the effect of the local anesthesia that we give during the procedure. So, but don't forget that you have to give local anesthesia for treatment that need local anesthesia. Extraction, give local anesthesia. Pulpotomy, give local anesthesia. But the good thing about the sedation is that it will increase the analgesic effect of the local anesthesia and make it more profound. Okay. And during, how did you recover?
Was that I felt that the recovery is very fast. And the change from 65 to 60, that was the fastest. Yeah, the moment when you changed that, I really stopped.
Yeah.
And the laughing, I really couldn't control it, to be honest. And it did not come from the beginning of the 65.
Yes. So that's what always
it took time.
Yeah. Some might laugh, some might cry. So that's in the very deep sedation when you reach more than 35 and 40% of the nitrous oxide. Then you will feel the patient is laughing. That's what they call it, the laughing gas.
Yeah.
I feel now I'm a bit sedated.
Really?
Yeah. So you might need to drive me back home. So this was our demonstration. So I make sure that he's okay. He can walk alone and with an escort of a parent or a guardian. And if for an adult, make sure that he can drive, and recommended not to allow an adult to drive alone. Have someone with him to drive and take him back home. And I think going back to the question, if you mean how do you know the hypoxia? Hypoxia, usually when you have the hypoxia, the patient has low oxygen, you will see some kind of like bluish discoloration in the oral cavities. It gets bluish, patients feel headache and drowsiness and feel like being fatigued. That gives you sign of patient having hypoxia. Is you okay now?
Yeah.
No hypoxia? Any questions? It was a great pleasure having this demonstration with you guys, and we will put the article, we'll upload it online, and you are all welcome to come here and try nitrous oxide sedation, but only for the first time. I'm sure if you come try it for one time, you need to try it more and more and more every time. So would you like to try it again?
Definitely.
Definitely. Okay. But he's not allowed to do that. He has only one trial. Yeah. Okay. Any questions there?
I'll have my ways.
Oh yeah?
I'll have my ways.
Okay. So, thank you everyone. Thank you for your time. Thank you for listening. Thank you, Mustafa, for being here and helping us.
Yeah.
Thanks for the Torheb for being the director today. And have a good night, everyone.
Good night.
Bye bye. Bye bye.